Hi everybody, welcome to this very important lesson about congenital hypothyroidism. And the simple question I want you to be able to answer at the end of this lesson is, does my patient have congenital hypothyroidism? Every general pediatrician is going to encounter a case of congenital hypothyroidism sooner rather than later, so it's important to know how to go about dealing with this patient. Let's get an example first of a clear-cut congenital hypothyroidism. Let's say patient A. This is a patient that has a newborn screen that is screaming congenital hypothyroidism. The TSH is up in the hundreds, let's say 100, and they have also a low T4. The T4 doesn't necessarily have to be low, it can be normal, but the TSH of 100, even in the absence of symptoms, is indicative of congenital hypothyroidism. But say they do have symptoms or they even losing weight while you're seeing them, this is a very easy slum dunk diagnosis. You have to call this kid a presumptive congenital hypothyroidism. So the first thing that you should do when you see them in clinic the day that you get the newborn screen is get another blood sample, but even before those results come back, start them on treatment. Start them on levothyroxine treatment. After that, you can wait for the results to come back to verify your suspicion, but the most important thing is to start them on treatment. Even if it's not congenital hypothyroidism and it's a false alarm, they're not going to get hurt by a dose or two of levothyroxine. Now let's take another patient. It's a patient that has normal thyroid hormone levels, no symptoms of congenital hypothyroidism, they're actually gaining weight and doing fine, but in your testing or the newborn screen testing, the TSH has come up as slightly high. And we're going to talk about what slightly high TSH is. Let me emphasize here, it's a normal T4 for the whole period of the investigations. And when you're doing your own testing, I encourage you to always get a free T4 level. Instead of getting a total T4, always get a free T4 for any patient with thyroid disorder. So let's see what the timeline for the investigations should be for this patient. This is not an easy come to the clinic, start them on treatment and wait for the results. Again, we're emphasizing normal T4, so we're focusing on a slightly high TSH. So let me put a timeline here. This is our timeline in green. And I'm going to put a few hours will indicate the visits or the blood checks. All the way to the left here, this is where your newborn screen was done. And a week later usually is when you verify that with a blood test. But there's two time points where you're going to repeat those TFTs. You're going to get a TSH and a free T4. And we just said the newborn screen is going to result back in a week. But that repeat after the verification can happen, it depends on the patient, within 1 or 2 weeks at each time point. So most pediatricians will communicate with us, contact your endocrinologist, and then find out how long you should wait to repeat it. But those repeat samples are very important because they're going to set the trend. And I want to put this in a little bit bold letters, and I want you to remember this phrase from this lesson. The trend is your friend. This is the most important phrase for this lesson. Say one more time with me. The trend is your friend. So allow me to draw a graph here where on the y-axis we're going to have the TSH and on the x-axis we're going to have the same arrows we had above for our timeline. So we have a newborn screen to begin with. You have your verification blood test as soon as you get the newborn screen results, and then you get your repeat 1 and then your repeat 2 sample. So this is a timeline that should last about 3 to 4 weeks in total. I'm going to draw 2 dashed lines here for the y-axis on the TSH. The lower one is a TSH of 5, and most commercial labs will have an upper limit of normal close to that, but the other one is 10. And remember, this is only TSH we're talking about. I'm going to put it in yellow here and in asterisk. These patients have normal free T4 no matter when you test during this timeline. So let's talk about a patient in the light blue, what the ideal scenario would be. Let's say you have a TSH of 12, 15, and by the time it comes back, by the time you verify that blood test, you actually get a TSH that is 6, 7, and it stays like that after you repeat it. So you can see clearly now the trend is downwards. The trend is your friend, so this is a patient that you can say it's a false alarm. The reason why I'm saying it's a false alarm is because with the most recent congenital hypothyroidism guidelines from the Endocrine Society, a value of less than 10 for an infant is normal. So we're looking for a value that is less than 10 at any time point. Let's take an example of someone that doesn't normalize that quickly. We're going to make them here in the dark yellow. They start about 12, but in your verification lab and the first repeat, they're still above 10. And it takes them about a month for them to drop down to less than 10. But the trend is your friend and the trend is downwards overall. So again, this is a patient that is a false alarm. But here in red is someone that we might have a problem with. So they start around 12, 13 together with everybody else, but they consistently stay above 10 no matter when you test them. And by the last repeat sample, about a month later or 3 weeks later, you can see they're trending upwards. So they're telling you that they're diverging away from what the normal values is. This is a patient that needs treatment. Let me scroll down here where we can talk about the conclusions that we can draw from this graph. Number one, it's important to verify, because it might indicate you immediately that you're dealing with someone that is a false alarm. Number two, you have to trend the thyroid function tests a week or two later and then a week or two later after that. The trend is your friend. So then in time, you will know what patient is treatment and what patient can be called as a false alarm. Number three, it's important to recognize that even though you're doing a commercial assay, the upper limit of normal in the assay will not be normal for the age that you're dealing with. A value of less than 10, according to the most recent congenital hypothyroidism guidelines, is normal for an infant, for someone that is less than a year old. So let's zoom out, scroll back up, and review what we talked about. We said the most clear-cut example is an example of someone that has a sky-high TSH, and it might have a normal or low T4, and for that patient, the most important thing is repeat the sample as quickly as you can, but also place them on treatment ASAP. And then you can wait for the results to come back later. The more tricky patient is a patient that's always had normal thyroid hormone levels, but we're focusing specifically on a borderline high TSH. A patient that is clinically thriving, doesn't have any symptoms. So normal free T4 for at every time during the investigations. We said that the trend is your friend, and that's the most important thing to remember for these patients. There's a few time points that we need here. The verification of the newborn screen is first, but then you have to trend those thyroid function tests in time. And either you'll know immediately that you're dealing with someone that false alarm if they've normalized, or about a month later, you would have picked out the patients that need treatment as opposed to patients that have normalized the TSH by that time. So, in conclusion, verify immediately as soon as you get an abnormal newborn screen, and then trend your thyroid function tests for a couple of time points, and keep in mind that a value of less than 10 is what you're looking for according to the most recent guidelines. Thank you so much for listening. Make sure that you check out the other endocrine videos online.